From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson.
Today is Tuesday, the 20th of May, 2025. Our guest on LabMind today is Dr. Octavia Peck Palmer, immediate past president for ADLM, the Association for Diagnostic Laboratory Medicine, known to many of you as AACC if you've been around for a while. Dr. Palmer is Associate Professor of Pathology at the University of Pittsburgh, where she directs the Clinical Chemistry Division and is also Department Vice Chair of Health Equity, Diversity, and Inclusion. Dr. Peck Palmer received her PhD in Physiology from the Medical University of South Carolina, followed by a Clinical Chemistry Fellowship and a postdoc fellowship at Washington University in St. Louis. Octavia Peck Palmer, welcome to LabMind.
Well, thank you so very much, Dr. Jackson, and thank you for the kind introduction.
I heard you speak a couple months ago at the Lab 2.0 meeting in Chicago, and within about 2 minutes, I thought, we've got to get you on LabMind. It wasn't your subject matter, it was the way you talked about your subject matter, and hopefully we can get into that a little bit deeper in a few minutes. But let's start with your personal journey. How did you get into clinical chemistry, laboratory medicine as a career path?
I'd say my personal journey is interesting. As many of us who have PhDs in science, we do basic science research. For me, it was examining the sepsis pathogenesis, both in vitro models of infection and animal models of infection. And the plan after those 5 years was to pursue a postdoctoral fellowship that then would provide me the opportunity to become a principal investigator and be able to write grants and fund grants and mentor pre and postdoctoral students. But those plans changed once I attended the experimental biology meeting, also known as the Federation of American Societies of Experimental Biology, FASAB, and had the opportunity to meet with and learn about clinical chemistry from several different organizations. And at that time, I met with Dr. Mitchell Scott, who was one of the co-directors at Washington University School of Medicine Clinical Chemistry program. And I learned more about that program, and I went away from that meeting thinking this is the way that I can apply what I've learned during my pre-doctoral training. And actually, it's a way that not only to be able to aid patients who become septic, but to aid patients who have a myriad of diseases. And so from there, I formally applied to the program, got some offers from other programs, and was able to select WashU, where I would receive my clinical chemistry training, and had some fantastic mentoring from Dr. Scott, from Dr. Jack Laytonson, and also Dr. Ann Gronowski, who is now the co-chief of the Division of Lab and Genomic Medicine. So my journey to clinical chemistry was not planned, but it's now history, and I've enjoyed every minute of it.
Those are some big names that you just mentioned.
Not only is it just the name, but actually in their actions of how they see you, not just being someone that participates in a fellowship and then goes out to the world, but someone who they want to continue to pour into, to mentor, to advise. And I'm really thankful for those opportunities and still am.
Now, in your current role, you're director of the Clinical Chemistry Division at University of Pittsburgh, which is a pretty traditional, familiar role, I think, for people in this industry.
Yes.
You also have a title that includes the term DEI in it, which I think is a little bit less common. Where did that come from? Was this a position that existed before you got to Pittsburgh? Was this something that you talked to people about?
This position was not a position that currently existed in our Department of Pathology. However, vice chairs of health equity, diversity, inclusion, they do exist within the University of Pittsburgh School of Medicine. And so because of that, I knew about the work that was being done. I benefited from that work, along with even benefiting from being able to have internal grant funding to do work in this space. And so when my chair, Dr. Laurent Ron Pantanowitz was recruited back to the university to become a chair of the Department of Pathology, he became aware of the research, publication, and leadership that I had in that area. And then he approached me to originally serve as vice chair of DE&I. I asked him would he consider me being health equity and diversity inclusion, because for me, it wasn't the DEI of human resources, because we have a really good human resources program here at the university, but it was me focusing on developing other faculty of using this health equity lens to practice not only lab medicine and pathology, but medicine in general. How do we demonstrate the metrics of health equity in a manner in which people understand what the positive outcomes are of it? And so that's how we got to the point of me being vice chair of health equity.
That's a really interesting point you just made about human resources. I think that the terms diversity and equity in a lot of large organizations, it's just assumed that that's a human resources issue, or that's something that sits in human resources. But actually applying this in laboratory medicine in a scientific and clinical field just strikes me as much more interesting.
I felt the same way, and I'm glad that resonated with you.
Now, you've clearly written and spoken extensively about these topics. Where did your personal passion for studying and thinking about health equity start?
My personal interest is personal because I do want to live my healthiest life. And I want to make sure that any barriers that exist are removed so that I can do so. I think that it actually happened during the process of me working on my dissertation, because my understanding of sepsis was a racial and ethnic disparity in outcomes of sepsis, and not even the outcomes of sepsis, but one being diagnosed with sepsis, so that delay in diagnosis, ultimately what treatments could be provided to the patient, because unfortunately there's no cure for sepsis. And if you do survive sepsis, you have a host of quality of health issues, from limited mobility to almost a PTSD type of mental status that you experience from having that disease, to cardiovascular disease. And I could go on and on. But I think that it really began of me conducting research and demonstrating that we could do better in how we identify individuals with sepsis. Secondly, health disparities exist across the myriad of diseases in healthcare access, therapeutic access, economic, education, attainment. And so all of these things impact me, impact my family, impact my friends. And I really want to find a way to contribute to identifying those social determinants of health, those non-biological factors that actually mediate health disparities, but ultimately, how do we eliminate them? And that can't just be done by myself or one group. It really does take everyone thinking about what piece they play in this. So that's really where my interest sparked in these areas.
It seems to me that within clinical medicine, and I could use the term scientific medicine, that as a profession, I think we have a self-image that we are purely scientific, that everything is objective, everything is biological, everything is chemical. When you talk about health equity issues, and maybe you could apply this to sepsis where you did your research, how much of the inequity comes from physical and biological issues, and how much of the inequity comes out of social and cultural factors?
That's really important. You do have a point. When we think about science, we want to have that control, that variable, look for those differences, determine if they're significant or not. But in science, if you don't have a representation of the individuals that you're trying to draw a conclusion on, that's where health equity comes from. Whatever you actually find as your conclusion is not generalizable. It may not really account for the other biological or social factors that actually interfere or aid one as they progress through life. So if we talk about biological, we could think about genetic makeup, mutations that actually have downstream effects on how one metabolizes, how one produces an enzyme. We could also think about social factors, thinking about culturally my diet and what I eat, and how that ultimately may change creatinine values, or it may change protein levels. And so if I've only made or established reference intervals in a certain populations that are non-vegan or only this type of food or is this body weight, and then I try to generalize that data or those findings across other populations, I've actually minimized the work that I'm doing to develop these reference intervals. So I would say that when we think about how we practice medicine, we all are different. And we need to start to think about what are those differences that can be social and biological and how they're interconnected. And ultimately, that's how we want to treat individuals. And that does lead us to personalized medicine. That leads us to the ability to determine how treatment is going to be given to certain populations versus others. So there is a level of not thinking just biological, but thinking socially how individuals are impacted throughout life and how those social impacts affect how they show up on a daily basis.
So the way you're talking about this is presenting a much, much more complex and I would say much more interesting picture than maybe the way that diversity and equity sometimes gets talked about in society. Let me maybe propose an idea that you can react to. Let me go back to the HR department. And I don't want to, if there are any HR professionals listening to this, I hope you don't think I'm criticizing you, but I think there's a cultural issue here. It feels to me that issues of diversity in popular discourse often get reduced down to box checking and putting people into buckets. And that's not what I hear you talking about, but I think that that's the way these issues often get thought about. And the HR connection is that HR departments tend to be very compliance oriented. React to that a little bit, this idea that you can reduce diversity to putting people into discrete boxes versus, no, that's actually the problem in the first place that we're trying to break out of.
Correct. And I agree. And I think what's key here is that if we reduce it to compliance, we are really minimizing the innovation that comes out of diversity, equity, inclusion. We minimize the financial rewards. It's performative. It leads to distrust. It leads to deeper inequality. It's more top down, tokenistic. Here we're thinking about what would resonate with lab medicine and pathology and medicine as a whole is we are removing shortcuts that are based off of what one may say work that has been done in, I'm going to call silos of populations or groups. And we have to think about the intent of DE&I. The intent here that these principles become embedded. So how would you embed it in medicine? Well, we think about clinical trials. There's a lot of work in the areas of demonstrating how can you diversify your clinical trials from the way that you enroll. You think about your eligibility criteria for inclusion. You think about the equity that one will be able to at least articulate and say, the outcomes of this study are equitable because of X, Y, and Z. So if I am trying to determine how a certain mutation impacts the way someone metabolizes the drug, it's imperative that I have a cohort of individuals that represent who I'm going to administer this drug to, market this drug to, and not assume that gender and age and body weight and even the biological prevalence of certain mutations across ancestral populations don't exist. And so from there, I feel that we are more innovative, we're transformative, we're thinking a lot about people so that we can actually deliver personalized medicine. I think I would add on to that also too is that when we talk about DE&I as a human resource, and since I'm the one that brought that up as human resource versus medicine, we do have to be cognizant about why we decided to bring one person into a leadership position versus another individual. And it can't be that DEI says I have to bring in a woman, or I have to bring in someone that has a disability, or I have to bring in someone of this racial group.
Which would be very much a box checking activity, right?
That's exactly right. And that is what I think people are turned off from seeing and understanding what DE&I is. And that is not what it is. It is thinking about why has only one demographic or one group only held these positions? And how do we find ways in which we can utilize the expertise of individuals that may not look like this group, may not have come from these regions and areas? And so it allows us to really think about why we're currently doing what we're doing right now, and how do we ensure that we do it in a manner that gives other individuals with similar, if not more expertise to be able to have those positions if we're going to talk HR. So yes, it's beyond the box checking, and you're right. And I think the backlash of that is that it's not fully articulated about what are we trying to do here? What is the strategic plan? What is the culture in which my organization actually works within? Is there trust among the group? And what does that trust look like? And I would say too, you don't just learn DE&I. You don't just have one training from your supervisor and then you go about your life. It is a constant understanding different cultures, the constant understanding of how people learn, how people interact, environments. And that's the part that is very important, is that these are just not trainings. It's the constant understanding and a cultural shift of how we think about things.
I want to go a little bit deeper into this relationship between health equity and personalized medicine. It's not a connection that I hear or see very often in our field. I think you're onto something big here, but diversity and equity tend to get framed as social issues and sometimes legal and compliance issues, but definitely on the social science side of things. Personalized medicine has traditionally been framed as very much a hard science problem.
Yes.
In the sense of, biology and chemistry and genomics and things like that. And you're connecting these two up. So explain that a little bit. Make the case that these are really the same thing.
Yes. I would say my case is going to be, they're not the same, but they are a complex interaction or interconnection between the two that exist, because the goal of both of them is to improve health outcomes. And they want to recognize, celebrate the fact that individuals differ, and those differences are due to biology and social constructs. And so, in order for you to have health equity, where you're saying that everyone has a fair opportunity to obtain their highest potential of health, regardless of political, social, demographics, where you live, disability status, you can obtain your highest health possible. And personalized medicine says, because we want you to obtain the highest possible health, we'll then tailor your medication, your therapeutic, your treatment to your differences. And I think that is key. And those differences could be genetics, environment, that pressure, the environment, that then ultimately we can talk about vitamin D. All vitamin D reference ranges can't be the same. I live in Pittsburgh. I'm from South Carolina. I get a lot more sun in South Carolina than I do in Pittsburgh. But does that mean that I'm deficient? Or does that mean that I have efficient quantities of vitamin D? And so we have to really think about our lifestyles. Again, going back to nutrition, what my diet is and how that could impact certain measurements in the clinical lab. Also thinking about pressures. If we start to talk about pathology, anatomical pathology, even some of the markers and stainings that we use, are the protocols that we're using appropriate to detect abnormalities in tissue so that we ultimately can make early diagnosis for cancer? Or do we have screening modalities at an early enough stage across populations to ensure that they have early detection? So health equity and personalized medicine really are intertwined. They're interconnected and they feed all of each other. And you really can't have one versus the other. I believe that innovation in personalized medicine is only going to come forward if we start to understand how to actionalize health equity initiatives in a meaningful way for populations.
So even if health equity and personalized medicine aren't exactly the same thing, it seems that you can't do health equity well or properly without taking a personalized medicine approach, and vice versa, so that they become inextricable from each other. I feel like it would be helpful at this point if we talked about maybe 2 or 3 specific examples. So you mentioned clinical trials. It's well understood in the clinical trials community that very narrowly defined clinical trials, say you study relatively healthy people with no comorbidities between the ages of 40 and 60, even though you know this drug is going to be used on 90-year-olds with 6 comorbidities. Can you think of 2 or 3 examples of real patient harm that came from the scientific community not fully embracing these ideas that you're talking about?
I think the one that many of our listeners will be familiar with is the estimated glomerular filtration rate that uses Black or African American adjustment. And where we have a study that was a small study that utilized about 197 individuals that were Black compared to over 1,600 of individuals that were white, and then a small group of others. And they saw in the Black population that there was about a 12% increase in creatinine, and they attributed that to muscle. However, they never measured muscle, but they did include that 1.2 adjustment within the EGFR equation. And so my case studies and others have demonstrated that this has an impact on how kidney care is delivered. And that impact for our own case study was a 70-year-old woman who had about a 12-month delay of even getting on the transplant list. It impacts how Black or African American individuals are triaged to determine if they can be kidney donors. But interestingly, while Black individuals are significantly impacted, there's research that demonstrates that if other ethnicities and races were given that adjustment, that in fact they have been impacted too. And so Vanessa Grubbs is a nephrologist for several years that highlighted this impact of algorithms. She has a really nice commentary piece called Let's Stop Playing the Race Card. And it really highlights that all of us are impacted when we start to use race in the way we deliver medicine. Because if you don't fit in the white box or the Black box, then where do our multiracial or non-Black or non-white individuals fit? And we've done a disjustice to these individuals by not including them in studies to represent them. There's some outstanding work, though, that I would say is taking place not only what I'm a part of, but there are several groups. One is a group in New York that has done a lot of work in the space of looking at various algorithms that use race for adjustment. The New York City Coalition to End Racism in Clinical Algorithms. And key is that they've in the past partnered with several groups, including the Association for American Medical College, with the idea of having educational content so that trainees and physicians and professional healthcare individuals will understand, because many people are not even aware that these clinical algorithms exist. And if I could drop one more paper, Dr. Darshali Vyas, with the senior author, Dr. David Jones, actually published in 2020 in the New England Journal of Medicine a very nice manuscript titled Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. And it demonstrated that across many of our medicine specialties, there is some type of race-based equation being used that modifies results that the clinical laboratory are actually directly measuring in that patient. And so maternal serum screening has race adjustment, preeclampsia risk in the first trimester has race adjustments, pulmonary lung function. The American Heart Association gets with the guidelines heart failure group. And so as we think more and more about these race algorithms, we do have individuals working in this space, just like the New York group. There's also a group of several hospitals located in the Philadelphia area. This was convened by the Independence Blue Cross group. I believe they're called the Regional Coalition to Eliminate Race-Based Medicine. But these groups, including Penn Medicine, have taken into their domain 15 various algorithms that use race. and they're working on those as a system to remove those. And they reported in 2023 that more than 700 patients alone have advanced on the kidney transplant list. Of those, 63 actually received a kidney. They demonstrated impacts in the Hispanic population, the Asian population, when it comes to things like anemia detection. And so there is substantial work being done in this place. And as we look at health equity being a medical model, we see the impact that it has on society. Everyone wins in this.
So I was aware of the existence of that GFR estimation algorithm. And years ago, I wouldn't have questioned the decisions about which factors to include in the algorithm. I am surprised to learn from you today that there were fewer than a couple hundred Black individuals in that population that they used to create a formula that's been used incredibly broadly. And then you point out all of the harms that have come from this, of individuals who didn't receive kidneys, for example. That's a big deal. All attributable to what sounds like a very unfortunate decision to include some very, very limited science. I didn't even realize how limited that was.
Yes, when we think about our health disparities, that does impact society because then we have individuals who are no longer healthy. They can't contribute. That's a financial burden on the system. And so, really, the goal here is we should be thinking about a concept of wellness. How do we find a way as organizations to be profitable on health? I like to say health is wealth. And so, how do we find a way to tie wellness care to what our organizations need, which is dollars, in order to be able to do what their goals are, their mission, their vision, and to achieve that. And we can't do that when our population is sick.
Let me bring up another example to react to. In addition to being a clinical pathologist, I'm an informatics guy. And so I find myself in conversations about things like reference intervals. An interesting example that I've heard come up from time to time is a discussion about reference intervals for hormone measurements, particularly in the context of trans individuals. And this idea of, well, we need to identify which patients are trans so that we can create trans-specific reference intervals. That's sort of the direction that I've seen some of the health IT companies going, to say, oh yeah, we've taken care of this problem because we created another bucket in our system, another flag to represent whether someone's trans or not. And when I hear these discussions, the first thing that I think is, all trans people are not alike. There's more hormonal diversity in that population than there is in the rest of the population. Some people are taking hormone therapy. Some people have had different kinds of surgeries. Some people have transitioned without doing surgery or hormones. There's huge variation. Simply putting a label to say you're trans and we're going to compare you against everyone else who's trans, that just strikes me as a really bad idea. React to that, and we could tie this into how we should really think about this situation.
It is very important to understand how people self-identify. So if they are identifying as a transgender man or woman, and understanding, like you noted, are they now actively taking hormones? And if so, how would those hormones interfere with any type of clinical testing that is being performed on them? So that one, we can identify if there are critical values in which we need to alert their clinician to, or two, to ensure that their hormone therapy is effective at the level the physician is seeking. So when you say checking a box for if you are male or female transgender, it's important to think about what would a reference interval help you with. So Dr. Dina Green and Dr. Matthew Krasowski has given us some really good literature for us to be able to incorporate within our own healthcare systems. And it's something that we have been looking at. How do we deliver this care with this knowledge that they provided us? One is, it's more than just saying I'm a transgender individual. It's saying Am I actively on this hormone, other treatments that I'm on? And ultimately having that information and then looking to see, are there hematology or coagulation changes, abnormalities that we should be identifying for this individual specifically because of what that hormone on that medication actually does. So that is another way to be inclusive as a laboratory. I will give you some other instances, delayed care in this population. Let's say that there is a tissue sample that comes across to the laboratory. It has a name that is more male facing. And so if you have a uterus or you have a placenta, that can delay care because the clinical lab is thinking this was a mislabeled specimen. If you have a PSA that comes down and it has a more female facing name, then that's going to delay those results because the clinical lab is trying to figure out, is it mislabeled? And so being able to be inclusive in the way that we offer our own IT systems, that you get as much information as needed, not only their legal name, the name that they go by now, so that it's very clear, but this population also has to feel trust and respect from the way that care has been delivered. And historically, we know that there have been published reports where care has been delayed for them. And Dr. Dina Green's paper, specifically looking at the estimated glomerular filtration rate and the patient, they're not knowing, do I use the woman or do I use the male calculation to calculate their EGFR? And then ultimately there's a delay in care for dialysis and a kidney transplant. So it does go more than, like you've noted earlier on, just checking these boxes for individuals. There's more below that. And biologically, we do need to understand how different medications and biological changes actually impact what we measure in the clinical lab. That's more work that needs to be done in that space.
It feels to me as if the entire field of laboratory medicine needs to go through a mindset change because we have decades and decades of thinking in terms of averages. And everything you're talking about is thinking in terms of individuals. And I'm not sure we have the systems and the science and the data tracking and everything yet to do that. But it feels to me like this is the right direction to go.
I believe that's the right direction. We have the tools. I'm not sure we just understand how to deploy them. So there should be a baseline on you and I, but that would be wellness care. And that baseline could be followed when we do present into the healthcare system, but that requires ITs that communicate to each other. It also lends itself to think, what are my goals for health versus your goals for health? Do I want to undergo chemotherapy or radiation for cancer? And maybe you don't. And so again, I have a voice. I'm working within the space of being able to contribute to what I deem as the best care for myself. I would also say when we think about blowing up the whole system, it's not just lab medicine's fault. We think about when race was first introduced into the practice of medicine in the 1700s, and that idea of there's an essential difference. And so the skull is different in slaves, the pelvis is different, the lungs are larger. And so these are things in which you think about, you're trying to get the superhuman to be able to be the slave. Or Black individuals feel less pain, their skin is thicker. And so when you have this type of myth or these stereotypes,
They find themselves into medicine, right?
they find themselves into medicine and how we practice medicine.
Yeah.
I would just also add to the fact that many of these adjustments are not done by lab medicine or pathology. They're done because they're legitimized by medical professional societies who have said, this is the way we're going to calculate X, Y, and Z. And so the lab many times does not know that a sodium calculation has been adjusted for race in the healthy heart calculation, when in fact we can measure sodium. There's no need to adjust for that. Having the lab at these tables and a part of societies that write guidelines and may not understand what we do in the clinical lab or what we do in pathology is important. And I think that lab medicine, in many ways, we're leading that effort and we are working with different individuals in different disciplines. That does make me happy.
In our last few minutes, let's talk about a different subdomain of equity and diversity, which you mentioned earlier, which is the organizational side of it. So, for example, recruitment. I had a conversation recently with a research collaborator, and he was telling me about a highly respected graduate program in hospital administration. So I looked up their website, and what struck me was on the page where they highlighted their faculty and their expertise in hospital administration, almost everything on that page was about diversity. Now, my first reaction was, oh, this is a nice thing. I'm really glad that future hospital administrators are learning about the importance of equity and diversity. But then it started to strike me a little bit funny. And I was thinking, well, they're not saying anything about clinical operations and their expertise in that. They're not saying anything about cost accounting, which is awfully important to a hospital administrator. And again, I'm not going to name the organization, but it just gave me the feeling that maybe they were talking about equity because they thought that's what people wanted to see.
I think we have to step back and think about how did we get to DE&I being highlighted. DE&I has been in the social sciences for over 5 decades. They've been talking about DE&I and social sciences. It is medicine that is catching up. Some organizations fail at DE&I who I believe were going to be committed to it because they didn't know how to take DE&I principles, align them with metrics that they cared about within their organization, and then tie that to profits. And the profits are financial, the profits are staff, wellness, well-being, lack of turnover, innovation. In 2015, McKinsey report said companies that were gender diverse, they had about 15% increase in their productivity, which aligned with finances. For businesses that were racial and ethnic diverse, their innovation and their financial increase was over 30%.
I really love tying these social aspirations to organizational strategy and identifying where are the places where this is a win-win. And I don't mean this to sound cynical. Obviously, as individuals, we should be doing things that are socially beneficial, regardless of whether it benefits us personally. But at the organizational level, programs and activities are much more sustainable over time when there's a win-win.
Yes, I agree. There has to be something, there has to be a product, there has to be an outcome that demonstrates that the metrics have been met and that the organization is better for it. And it requires accountability. So we have to be transparent. What are we talking about here? Are we talking about health equity from the standpoint of a medical model that we are going to institute and hear what the outcomes are? Are we talking about DE&I because we look at our boards and we look at our leadership and it doesn't reflect the population that they should be serving? We have to be very transparent about what are we focused on here and what kind of changes do we want to take place?
For my final question, I want to get back to a pet stereotype that I like to bring up in these interviews. Pathology and laboratory medicine have a longstanding stereotype that people go into this field because they're introverts. They'd rather live in the lab so they don't have to deal with real people. It strikes me that this is not you. You are clearly an extroverted person.
I am an extrovert.
You'll own up to it. And this is backed up by your professional activities, seeking leadership positions at a relatively young age, for example, president of ADLM.
Thank you for thinking I'm young. I'll take that.
I'm the one with the gray hair in this interaction. When you work with trainees, residents, fellows, how do you engage with them on topics such as pursuing leadership opportunities, engaging with the clinical community, basically getting beyond the bench and engaging with people and making this a people profession and not just a biology and chemistry and microbiology and engineering profession?
Yes, what's interesting is that when I took my first job in 2008, which I've been at Pittsburgh ever since, I kept hearing that pathologists and laboratory medicine professionals are introverted and they like to stay within their four walls. And I thought, oh my gosh, I didn't realize that was the type here. Maybe I have selected a different path. But the more and more I engaged, I realized the mentors that I had sought, they didn't personify that model. And also, in order for us to be impactful, I kept hearing, you need to be at the table. Where is the table? Do I create the table? How do I get invited to the table? And so it's like a constant push and pull of thinking about, where does lab medicine and pathology sit? And I will say, the fact that I believe we actually generate a copious amount of data that is not being used at its full potential demonstrates our value and the wealth of what we have. And so my hope, and I know people that are doing that work in that space, including you, how do we utilize the wealth of our data to the good of people? And so that's what I press onto my residents and trainees. I highlight to them, my medical students, they can't believe that, number one, this is what lab medicine does. Then they think, wow, we are making guesses if we don't have the data from the clinical lab. So I am constantly sharing with them, think about what you're most passionate about. And for me, it started with sepsis, wanting to find that cure that still evades us, understanding that people actually aren't getting the care that they need, but that's across diseases. And so, how, as a laboratorian, can I ensure that the way that I practice is appropriate? And one is, I created the Ask the Laboratorian event. And the goal is to go outside of the lab. And so we've gone outside into our community. We've shared with them who we are, what we do. I've taken a clinical microbiologist with us so they see our faces and they know that we exist. And we also aid them in health literacy. And I would just challenge all of our clinical laboratories to think about, how much impact do we have? Because that's what our residents and our trainees and our medical students see. The more they see the lab out there answering questions, being a part of the diagnostic team, that then aids them of thinking about how they shape their career and how they're impactful. And the leadership opportunities will come after that. I've had great mentors. I've extended on educational opportunities to learn more about not just testing and automation, but budgeting and what does it mean for account costing and contracting. And so I want to bring a better piece of myself to aid the healthcare organization as a whole and how they deliver care. And lab medicine is the vehicle to do that.
Dr. Octavia Peck Palmer, thank you so much for being on LabMind, for sharing your insights, and frankly, a really compelling vision for the future of laboratory medicine.
Well, thank you so much. It's been a pleasure.
LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.